So very good afternoon to all. I think it's already 12 noon and free lunch session, not the best one. Always, we are looking forward to eating. So let's see, we'll hopefully get through this hour together. So I have slightly modified the title because I felt that the big picture was important. So rather than jumping directly to the data sources, after talking to many of you yesterday, and also understanding the kind of audience, I felt that I should begin with the broader perspective. And and then we will try to build the connections. What I really like about this workshop is that the diversity of people in the room and the ability to make those connections, very unique connections. So I thought this may be an ideal opportunity to sell public health research to many of you, and hopefully some of you will go on to take up work or careers in that highly neglected area in India. So I come from National Institute of Epidemiology, which is one of the institutes under Indian Council of Medical Research, and our major areas of work are epidemiological research, field epidemiology, outbreak investigation, strengthening the health system through public health research, and implementation research. So what I shared with you yesterday was from implementation research experience, connecting the epidemiological methods to actually disease control. And today I'll be giving you a little bit broader picture on what epidemiologists do. And actually what we do has very close connection with what you do. That's what I realized. And hence a lot of opportunities for collaboration and actually enhancing the value of work that we do with your expertise. So let's begin with the basics. So I assume that many of you already know, but just for the benefit of those who might not come from public health background, what is epidemiology? Epidemiology is really the core science of public health, and it's the study of distribution. So I've underlined that, distribution and determinants of health-related states. It's not just disease. That's very important to remember. Epidemiology does not limit itself to disease. We look at health events. So the event could be beyond disease as well. As I said, that a lot of exposures are social or environmental, which are really not disease. So the epidemiological research actually has a much broader mandate to look at all those health-related states and specified populations. So what you study in one population may be very different. And I think very good example is what Uma gave, that the same thing when you apply to one population gives you one kind of interpretation, but your interpretation may change when your population changes. And that's something really, really important to keep in mind. And then application of that, application of all this knowledge that you gain to control the health problem. Again, it's not disease, it's beyond disease. So we look at health as a whole. And I just felt that, I wanted to give some overview perspective here. And I would really recommend for those of you who want to work in public health, this is a very nice brief course, Public Health 101, on the CDC website, which is free. Anybody can do it. And I just picked up some broad perspectives from there. So when we look at a public health approach, so how do we really look at the problem? So I think my idea of today's talk was really to focus more on how to ask the right question. I think it's really important to ask the right question. I heard many people saying that, I would like to have data set. Yes, you would like to have data set, that's fine. But what do you want to do with it? That depends on what the research question is. And if you fail to understand the big picture, you may ask the wrong questions and get the wrong answers, and then take it to someone and say, look, I did this wonderful analysis, but then the person says, but it's not useful for me because that's not what I want to know. So, that's why that bridging and understanding what is an important question or how that question will be connected to something in terms of improving patient care or public health. How is it going to make a difference? So that's really important. So I think we begin with what the problem is, why the problem is there in the first place. So again, very Uma has made my job easier because she told you about preeclampsia and she talked to you about many risk factors, right? That there are certain things which make a person more prone to get preeclampsia. That's what Uma was talking about. And then what works? Like, what is that I can do? Okay, now I have this woman with preeclampsia. And then she talked to you about aspirin. She talked to you about it's important to detect. First of all, it's important to diagnose, right? And then how do you actually put all this in motion when it comes to a clinical practice? So I think this is the whole continuum from understanding the problem to actually responding to the problem. And as we go along this talk, and I would like you to reflect on when you ask your research question. So first thing you need to know is, where in this continuum is my question? Am I working on defining the problem? Am I working on understanding why is it there? Am I working on the solution? And am I working on how do I scale that solution is what I spoke to you yesterday. Like we all know hypertension is a big problem. We all know it's easy to treat the hypertension, but that doesn't mean people are getting treated. Only 1 in 10 Indians have their blood pressure control. So that 90% who are not getting treated adequately is the gap. So it's not so easy. Just because you have a solution, it doesn't mean it will reach people. Uma has emphasized it repeatedly that, there are so many things that we can do, but it doesn't mean it gets done. So sometimes simplifying those solutions can also be a great contribution to improving health. So you need to see how you go from one step to the other. So mapping in your mind. So I think as you have heard through so many speakers in last 3-4 days, you try to map who was talking at which level in this continuum. And then this comes really where everything comes together. So, public health is an exciting discipline, and I would encourage many of you to build your career in that, simply because it's diverse. You don't have to limit yourself to just one area of work. That's why you are finding us in this MLHD workshop, where most of you are actually from other backgrounds, because we need to work across so many disciplines. The problems that you tackle in public health are complex, and this is just an example that you can see what all you need to do. You need to have a good epidemiological core science to actually answer the questions, but then you need to combine it with very good lab science. So most of the research requires good lab science, whether it is, finding the organisms for infectious disease control or other parameters, like Uma was mentioning some parameters today. And also I yesterday was telling you about cardiovascular disease. You need to look at cholesterol. And so you need very good lab information. You need informatics. And that's where I think many of you come in. We need really good informatics to make the right interpretations and conclusions. And you need surveillance. Surveillance is, I'll talk a little more about it, but we need to have a systematic data collection, which is happening over a period of time. And you continue to use the standard definitions while you collect that data. So you are able to make your interpretations. So quite often what happens is that different people collect data, but those are small data sets and they may use different definitions, and that makes interpretation very hard. So for the big public health problems, which we know that we need to focus on, we collect data through various kinds of surveillance systems. And I'll be talking a little more about that. So this is applicable. So the surveillance system may differ for different kinds of diseases, but we do need to have a system which is continuous, systematic, and where the data can be periodically analyzed, and then not just stopping with analysis. In surveillance, it's important that action is there. So the definition of surveillance itself includes action. It's an actionable data. It's not just the data that you collect, you write a paper and you forget. No, you need to use this data either to improve clinical care or to do public health response. So now what are the steps in solving the health problems? So you start with the data collection. And as I told you, data can be collected through different methods. You can collect it through surveys. You can collect it through different clinical systems. Now we have EHRs. and we also have paper-based systems. In the public health programs, data is usually collected by healthcare workers. They collect it again in paper as well as in digital form in several programs now. Once you have the data, you do what we call as a descriptive analysis. So you actually, there are several variables, right? So whenever you look at it, any problem from a public health perspective, first you try to look at the big picture of that problem. So what we call as TPP, time, place, person. So I think if there's one word you should remember from my talk, it's that, time, place, person. So what you do there, that is you try to see whether this particular condition or disease is increasing or decreasing over time, who is getting it, and is there a particular pattern in terms of whether people of particular gender or age group are getting it, or whether people who live in a particular area or under particular kind of conditions are getting the disease. So that gives you a kind of a big picture. And from that big picture, then you generate hypotheses. And you come up with various explanations, possible explanation as to why that problem is increasing, or why is it coming down, or why is it more in certain areas compared to others. And then you again do more in-depth research to actually test your hypothesis. So generate hypothesis, you test hypothesis, and then you come up with the intervention. And so as you go along these steps of solving a public health problem, the data plays an important role at each step. And hence, whatever advanced machine learning techniques you may use can help you at all these levels, starting from descriptive analysis to more in-depth analysis, and then to also testing the hypothesis. So I think I was told that I think Nikki has touched on study designs. So I'm just giving one slide refresher on this so that it will stay in your mind. So we use two kinds of study designs in epidemiological research. One is called the experimental, the other is called the observational. So the most of what we are talking, I think what, at least from what I've heard, you are hearing more of observational study designs and the work that is done through observational studies. So experimental is the one that is more of clinical trials, and I think that's not been a major area of discussion. So I'll limit myself mostly to observational research. But within observational, there are two kinds of study designs. One is descriptive and other is analytic. So going a little deeper into this. So when do you call it an experimental research versus observational? In experimental, you assign an exposure, means you actually give a drug or you give a particular intervention, whereas in observational, you don't do that. And in observational studies, you either try to describe the problem, right? Like as I said, that you just want to know who is getting affected and where do they live, what age group is affected, is it increasing or decreasing over time? And that's what we call as descriptive study designs. And then we have analytical study designs. So within analytical, we have cohort studies, case control studies, and analytical cross-sectional survey. I'm not going to go into detail of this, but whenever you start working on any problem, it's important that you talk to the relevant experts and find out, okay, suppose people have already collected data, right? You need to ask them what study design they used, who were the study participants, so you have a better understanding of what kind of analysis will be most appropriate for that particular data set. So just to give you a big picture, what questions you can answer with descriptive epi versus analytical epi. So in descriptive epi, you try to answer the question, who is affected? When did this condition occur? You remember COVID. COVID didn't happen at the same level in all parts of the country at the same time. We had big cities were affected first. And then COVID moved to smaller towns, then to rural areas, right? So it's not at the same time, the disease intensity is not same all the time. So, and then same thing, like if you take TB, TB has declined dramatically over years. But then the decline is not same everywhere. In some places, the TB decline is much more remarkable, but there are other populations. We have very remote populations like some of the tribal areas and so on, where actually the TB decline is slower. So you want to know why is it so? The second is who is affected and where do they live? It's really important. So epidemiology doesn't stop with individual, as I said, because why you have disease is quite often not just determined by your biology. Biology is one aspect, but it may be determined by where you live. So for instance, there are very interesting studies on from New York City where they showed that when the pollution level increased, the risk of getting heart attack increased. So you may have all the other risk factors which are just the same. You're same person, right? But just because you're living in a city where pollution level go up, your chance of getting heart attack goes up. So similarly, there are any number of other, I'm sure you all have watched movies on, a lot of movies on, environmental exposure causing cancers. There are very famous movies around that. So never forget the environment. That's very important. So where people live. So when you look at a data set, and if someone tells you, okay, this is the age, this is the gender, these are the, let's say, clinical variable or public health, don't stop with that. Always ask, where is this data set from? Where do these people live? Do they live in rural? Do they live in urban? And then try to assess what could be the exposures that you might not have thought of, right? So those are the questions you ask in descriptive epi. And what are the questions you ask in analytical epi? In analytical epi, you actually test your hypothesis. So once you have generated the hypothesis, you want to test your hypothesis. The hypothesis could be fine. The people who are living in heavily polluted cities have more risk of getting a heart attack. That's your hypothesis. But then you need to test it, right? For which you need pollution data. You need all the biological data of that person who got heart attack. And then in different ways, you can do a case control study, and there are different study designs, but then you need to put it all together to make sense of it. And you cannot just say, because you have data on, let's say, pollution, that's enough. That's not enough. Because different people will have different reaction to the same environment. So I think you learned a lot about genetics, and so genetics play an important role in what's your risk of getting a disease. Like there were a lot of studies on same exposure, like many of us, right? We were all exposed to COVID. Some people developed severe disease and others did not. So even for the same exposure, the outcome may not be same. It's determined by many factors, genetic, behavioral, your other biological risk factor. I'm sure you all read that, if you have hypertension or diabetes or heart disease, those people were more prone to getting severe forms of COVID, and hence they were told to protect themselves. So you need to take into account many factors and not just narrow down. Because your data set has something, you also need to understand what you can interpret from that, but more importantly, what you cannot interpret from that while testing your hypothesis. So this is the research cycle that we always follow. So spell out the research question carefully. I think that is the most important thing in research, asking the right question. If you are not going to ask the right question, you are never going to get the right answer. So spend a lot of time brainstorming, discussing with people, talk to different experts who have worked in that area, and try to come to the right question. And then, of course, it all begins with, so for instance, many of us who have been talking in this workshop are giving you our perspective on what we feel are the important research questions. So those are the needs. Like, for example, she told you, what will help her make better decision for her patients? Or I was telling you yesterday, what will help us make better decisions or provide better care for people with hypertension? So think about all those questions and then come up with the most suitable question. Then you go to the objective, choosing the right study design, then come analysis. And again, though there are many data sets available in India, I mean, people complain there's not enough data in India, but actually there is a lot of data already there. And I think we were discussing yesterday night also about that we are not adequately using even existing data. So you assess whether you want to collect data or you want to analyze an existing data set, depending on what your needs are. And then go on to analyzing, drawing conclusion, recommendation, and most importantly, sharing it with people who will use. Quite often you think that I have put it in a journal article or a conference, but I think that's not enough. You really need to take it back to people who will use it. So with this basic foundation of public health research, I'll be sharing with you a couple of examples. And these are just examples, and there are many more, and I would really encourage you to interact with others and learn about more possible areas of work. So as I said that, once you have decided what kind of question you have, then you need to make sure you are picking the right study design. And here are just few examples. So if you just want to know what proportion of people have a health problem, the data that you will take is more of cross-sectional data. That is, at one time, there are various surveys which collect this kind of data. Like we have National Family Health Survey. There's been a lot of discussion on surveys in the recent days in media. There is a national sample survey, and many of these surveys collect data on diseases. So there are huge data sets already available. They are cross-sectional data sets at one time. If your question is, what are the risk factors? Why are people getting a certain disease, and what possibly could be exposing to them? Then your study design has to be a case control or a cohort, and I'll be showing you one example of that. And again, you need to see whether this kind of data need to be collected or there are already cohort data sets available. So if you want to study risk factors, you need to get some cohort data set. If you want to study the one drug is better than the other or so on, and that's where you will look at a RCT data. So in my understanding, and I have very limited understanding of what machine learning can do, because I don't come from that background. What I'm trying to do is really building the bridge here. And in my understanding, these are 4 big areas where we can work together, where people from clinical science, public health, and ML can work together. So the first is really the distributions, getting a better understanding from the large data sets, which are very difficult to analyze for people like us. We do analysis to some level, but there's a lot more you can do with these data sets, where the focus is on TPP, time, place, person. Then quite often there are multiple data sets which need to be optimized and to make it more analyzable. I shared an example with you yesterday on NCD risk factor collaboration. They collect data from 1,000+ investigators all over the world. And then there are people who crunch that, people like you who use advanced method, they pull it together and make sense of it. And they do projections, they do models and all of that. The second area is really the determinants, where we can actually find answers as to what are the linkages of these diverse risk factors. I think Uma was trying to make that point that, there are so many different individual level factors. Then you have laboratory variables, you have genetic variables, you have all of this. And can we put it all together to make sense of it and see what risk factors are important in a particular population? So what I'm trying to say is, you may find studies which would have found risk factor for a particular disease in a particular population. It doesn't mean it will be same in another population. It could be similar. You may get very similar risk factor, but it may not be also. The third important area is really diagnosis. And again, I think there's a lot of scope for using ML techniques in imaging and diagnostics, and of course in clinical decision pathways. Understanding how we can make better decision given a set of parameters. If you are given to a clinician, can they make a better decision, putting them all together? Can that decision be better than a clinical judgment? You anyway make a decision, but can a particular tool help you make a better decision than a clinical pathway? And finally, of course, treatment and precision medicine, I'm sure you all have heard, is the thing of future, wherein there will be a lot more scope to individualize the treatment if you are able to pool all these multiple variables together. Right now, we don't do that. We use the same drug or the same regimen, irrespective of who the person is. Of course, some differences are there. Depending on certain risk factor, it may change. But broadly, it is quite similar. And finally, I feel there is a lot of electronic medical records data, which can help us understand the treatment practices better, which is actually not analyzed. And we could explore that. So I'm just going to use this as a framework broadly and walk you through a few examples. So this was a nice study. I was just looking up some literature, and there are studies which have looked at these large data sets which are collected at the community level to predict diabetes and hypertension at the population level. So I think you can read about this, but what I felt was that they were able to use very basic data sets to come up with algorithms. And I'm going to share a little story with you about the second thing, which is very close to my heart, which is cardiovascular disease research. As I told you yesterday, 1 out of every 4 deaths is due to cardiovascular disease in India. It's really the leading cause of death. And though we know it's a leading cause of death, and though there has been so much research globally, in Indian context, we still have scope for understanding it better. And in that context, there are many questions to be answered, which I feel can be addressed through this kind of interdisciplinary research. And the broad areas that I can think of is understanding the patterns of CVD. So it's very interesting. CVD is a broad disease. Like when you say cardiovascular disease, it actually includes heart attack and stroke, both, because both are vascular. So, the vessels in the brain get blocked or get hemorrhage, and that stroke, and then you have cardiac. But the stroke and heart attack do not occur equally in different populations. So for the same risk factor, for the same this thing, certain populations are more likely to get stroke, whereas others are more likely to get a heart attack. I don't know if you have read of any examples, but for China has much higher incidence of stroke, whereas the South Asian population has higher incidence of heart attacks. So although it's broadly CVD, the patterns are not similar, and we need to understand more about it. There was a study that I was part of, and we saw that Northeastern population, the deaths due to strokes were more than heart attack, whereas in the mainland, the deaths due to heart attack were more than stroke. Then yesterday we briefly talked about risk prediction, and I think in subsequent slide I'll be talking a little more about that. But the other thing is really the early diagnosis. Can we do something to pick high risk group early? Because right now we depend on people to report with chest pain, to come with fairly advanced symptoms, and only then we detect that they have the cardiovascular disease. Decision support tools, there are many available, and most of them again developed in the Western context, but can we do something for India? Personalized treatment plans and prognosis, again very important to know who is likely to get the second stroke or a second heart attack. So people who get stroke or heart attack once, they are actually very likely to get stroke or heart attack again. But within that, are there any particular risk groups? And can we identify those groups better so that we do much more surveillance or much more monitoring of those groups? So I'm just going to share with you, on the risk prediction, one example from my own experience, and then where the literature is going now. So when I joined NIE, I was very passionate about working in cardiovascular disease. So we started a cohort, and those days it was believed that NCDs were more a problem of urban population. I'm talking way back in 2005. And my mentor was very curious. He said, I don't think it's so. I think it's about time we start working in the rural populations. So we built this cohort in Tiruvallur, and we initially did many surveys, and we have published all of that, which showed that there was high prevalence of NCD risk factors in this population, like hypertension, diabetes, and so on. And then we went on to actually follow up this population for a period of nearly 7 to 8 years. And it's extremely difficult to do cohort studies because you have to keep going back to the same person, connect the data set, and then make conclusions. So the first survey we did was 2005 to 7. the second in 8 to 9, and the third in 13 to 15. So we documented what was the chance of a rural Tamil Nadu population to actually get a heart attack or stroke. This is one of the few studies from India where we were able to document that. And most importantly, we tried to look at what is increasing someone's chance of getting a heart attack or stroke. So when we look at this data, and I've presented it separately for men and women, because it was very striking that the risk factor, although the risk factors are broadly same, they don't play out in the same way. For instance, smoking played an important role in men. On the other hand, obesity was a bigger risk factor for women, but not in men. Similarly, the self-reported diabetes. So at that time, we didn't have funding to do the lab test. So we could only do the BP measurements, but we asked the history of diabetes. So the diabetes was a very important risk factor for women, but not in men. But what was striking was, and that's why my obsession with hypertension, as I told you yesterday, hypertension is a most important risk factor, no matter what age, what gender, which part of the country, which part of the world. So that's one of the very important predictors of heart attack or stroke. So this is a very, I would say, primitive study, right? In the sense that this was done with literally no funding. We had very minimal funding, but we managed to follow up this cohort with literally nearly 90% retention, which is considered very good in a cohort study. But what I want to say here is that there is a lot more that is predicting this risk, which we have not understood yet, okay? And for which you need larger cohorts with many more variables and being followed up over a long period of time. And let me take you to a very good example, which I came across from—
Just a question.
Yeah.
So I think central obesity has been understood as a risk factor generally, but it did not show up for men in your cohort, is it? Only for women?
Pardon?
Central obesity,
yes,
did not show up as a risk factor for men.
For men, yes.
Even though I think it's kind of regarded as the major risk.
Yeah, the prevalence of central obesity is also higher among women in Tamil Nadu compared to men.
Thank you.
Yeah. Okay. So, so if you look at these risk factors, now why did we pick these risk factors? So there is something called, I think you all might have heard, I don't know if you have heard, Framingham Heart Study. This is the biggest study ever done, which looked at cardiovascular risk factors. And based on Framingham study, which became like the study to really define the whole field of cardiovascular health, there were many risk scores which were developed. So this is called the cardiovascular risk score for South Asian, which applies to India as well. And this is available online, and you can just Google it, you'll find it. So here, what they have is, they have what they call as these risk charts. And what do these charts tell you? What is your 10-year risk of getting a cardiac event, okay? And they take into account age, gender, blood pressure. So there are two here. The one on the left is for people without diabetes, and one on the right is people with diabetes. And you can see more reds here, right? So diabetes is a very important risk factor. So even if you have less of other risk factor, but if you're a diabetic, your risk increases a lot more. So this is what is considered now, as of now, the gold standard. This is all we have really to predict the risk. It's a big question to ask how good it is or how good it is not. Most of the data that has gone into it, it's quite global in the sense they have pooled data from all over the world. But still, we have very limited understanding on some of the populations, especially we are a very high risk population as far as CVD is concerned, especially South Asian males are considered extremely high risk for cardiovascular events. So going beyond these risk factors, we really need to understand what else is playing an important role. And this was a very exciting study. I'm sure you all would love reading this. I can't understand the models they have used in this, but I can understand the interpretation. So what they did, they have taken this whole CVD risk prediction to the next level. So the UK Biobank is one of the most ambitious cohorts in the world, where they have very large number of participants who are being followed up over a period of time. And their data is used to do all kinds of research and all kinds of, sort of taking the whole medical science forward, understanding the risk and diagnosis and treatment and so on. And what they did, they used 473 variables. So now you understand why I said our study was very primitive. So they used 473 variables and they tried to see whether they developed a model and they tried to see if they are able to predict cardiovascular event better. So what it means here is they have all these risk factors and they also know actually who got a heart attack and who did not get a heart attack over a period of time. And then they try to compare how good is their risk algorithm vis-a-vis whether people got heart attack or not. They also compared it against Framingham risk score, which is considered pretty standard and which we already know that Framingham risk score will help us predict risk to a certain level. So they were able to say that, that they could predict 368 more cases compared to what could have been predicted otherwise with the Framingham risk score. And this is very interesting. They also then rank these variables to see which of the variables have actually contributed more. And it's very interesting to see that the classic ones still stand out. They made the maximum contribution. So these are 20 variables which they said have contributed the most according to their model. And the age, smoking, blood pressure, it's not going anywhere, right? So that's still there as very important. They also have put it separately for men and women because, somehow cardiovascular disease risk prediction works a little differently, predominantly because smoking may be really important among men. And then you can see there are other things like walking pace and so many other family-related risk factors, microalbuminuria, and so on, which actually contributed to prediction of risk. So this is a very, very interesting example of how we can use the machine learning methods to better understand cardiovascular risk. So now I'm shifting the focus a little bit away from,
Quite below self-reported health rating.
Yes,
And
yes.
I mean, is it because probably it was accounted for in high blood pressure as a part of metabolic syndrome?
No. Actually, BMI is not a good predictor, especially if you see it didn't come as a predictor even in our study. So yeah, that's a fact. BMI,
does it challenge the traditional metabolic X type?
No, the central obesity is a better predictor for South Asians. So there are a lot of studies now, even for diabetes, central obesity is a better predictor than BMI.
Thank you.
They looked at everything. These are the top 20. They looked at 473 variables. So if you go back, they have 473. So they have just mentioned the top ones here, which contributed more according to their model. But it's very interesting how so many new things showed up, which you would normally not think of. So I'm just shifting the focus now from the non-communicable disease to communicable disease, because that's another important area of public health research where there is extensive scope for collaboration between machine learning experts and public health researchers. And so since I come from NI, and there are 3 areas where we work. One is disease surveillance, second is sero surveys, and third is outbreak investigation. So disease surveillance, as I told you, surveillance is collecting data about a particular condition over a period of time using standard methods so that you are able to use comparable data and make interpretations. Sero surveys are extensive, large surveys which are done in the population. So you may get some conditions, like you may be exposed to a particular virus, but you may not know that you were exposed. So if you say, if I ask you, did you have COVID or did you have dengue? You may say no, but you may have antibodies for it, which means that you were actually exposed. So what sero surveys do is they help you understand what proportion of population has been exposed to a particular organism, although they may not even know that they were exposed to that. And of course, outbreak investigations, wherein this is literally, we have to sort of get into the war zone and try to find out why that outbreak is there and trying to map out and see if we can control it at the earliest. So these are our broad areas of work. And we have huge data sets, and my colleagues Sharan and Rizwan have been here, and you can talk to them and look for opportunities for collaboration in this area. So surveillance, I just want to touch a little bit more on surveillance, because I think that is an exciting area where ML and public health researchers can really do a lot of good work. So what do we do in surveillance? Basically, you collect data periodically, and it depends again for different surveillance system, collect data in different ways, and then you collate, analyze, make sense of it, and then use it for action. And this data is collected in multiple methods. Quite a common method is facility-based. So when a patient is coming to a health facility, they collect the health worker, and then the doctor will ask them symptoms, and then collect all that information, then send their sample for testing if required, and that becomes then laboratory-based surveillance. So that's all the facility-based surveillance, but that's not the only source. I don't know if you remember during COVID, there were door-to-door surveys, or the testing was made available even in the streets, at least in Chennai city, so that people could access testing easily. If they have symptoms, they may not feel like going all the way to the facility. So for many conditions, we also have what is called as active. So these are the technical terms. A passive is when you report to the health facility. Active is when the health system is going out, looking out for you. And we also have something called stimulated passive surveillance, which is done especially when you have an outbreak or something that you really want to, you have a system in place, but you want to further enhance it. So for instance, people might be coming to the health facilities, but you want to, let's say, do an additional camp and reach out and say, if there's a diarrheal outbreak somewhere, you actually want to reach out and say, go to that area if the nurse is there and say, okay, if anyone near in your house or nearby has diarrhea, ask them to come and report to me. So these are the methods by which the surveillance data is collected. And then in India, we have several big surveillance databases, which have potential for much more in-depth analysis than what we are already doing. The third is outbreak investigations, wherein you actually get on the ground and you collect data. You try to find out who is, so you start with the time, place, person. Then first you map who is affected. Is it more than what it used to be usual? And then are you able to pinpoint to certain specific groups or some particular geographic areas, based on which then you generate hypotheses. So these are the kind of sources where you have infectious disease data. And these are some of the data sources, not all, that I have listed here, which have huge infectious disease data available, where you could collaborate and do a lot of work. So the point I want to make is that some of these data sources are health, but to predict outbreaks, and especially the diseases which are influenced by a lot of other climate and other factors, you also need to look at non-health databases. So we have climate databases in India, we have GIS. There's a lot of good GIS data available in India. So you can map disease to the altitude, to the type of living conditions and so on, right? And then if you pool all of that together, you may be able to come up with newer insights which actually don't exist. And we do have some studies on those lines being done in India, but I would say there's a lot more scope to do this kind of research. And so how does this help? So for instance, you can answer many research questions. Why is, like, for example, there are some parts in India where repeatedly you get avian flu outbreaks, but not in other parts, right? You might have heard for brain fever outbreaks, which are more common in some parts of India compared to others. Or, dengue outbreaks. I'm sure you all have heard of dengue outbreaks. And they are more, again, they don't tend to be equally common everywhere. And they tend to affect certain populations more than the others. So a lot of these questions can be answered if you pool the data from these kind of multiple sources. So putting it all together is what we are not doing enough. Of course, there are few people who are doing it, but there is a scope to do a lot more work there. If you look at the literature, there's international literature coming now on predictive models for a lot of these big infectious disease conditions. So influenza being one, and my colleague Rizwan works on influenza. They are developing an influenza network in Tamil Nadu. So similarly, there are many such networks, but influenza is one disease which really has potential for a huge pandemic. We worry about it. I think historically you might have heard of it. There have been huge flu pandemics, which literally wiped out some parts of the population. And there is always a fear that the flu strain might be bad or worse, right? So there is a need to do continuous flu surveillance, but also to understand all the other predictors which influence why certain populations have more flu than others. So there's a lot of research going on globally now, how we can predict these patterns better. And a lot of work using ML techniques is being reported in the literature. So these are some of the examples that you can look at. Another interesting area where a lot of literature is coming now is on dengue outbreaks. Can you predict dengue outbreak? Like if you know there are places which have water bodies, which have certain vector density, certain kind of climatic conditions, then can you predict that these pockets will be more prone? And if you already know that, let's say, a state may have let's say 15 districts, and let's not talk about district, let's talk about even blocks or sub-district. A block is about 100,000 population. And then if you know which blocks are more prone to the outbreak, then when the season comes, dengue outbreak comes in particular season. So you can tell, okay, these are the more vulnerable blocks, and hence you should be putting more sort of preventive measures in place. You actively go, you do the source reduction, which means that finding any place where the larval breeding is there, or even alerting people that if you get a symptom of this kind, it could be dengue and you should report quickly. So this has a huge potential for prediction of outbreaks as well as better control of the outbreaks. So many factors play a role which can be studied in this kind of analysis. So I just want to share another example from our own experience, and this is not using any ML technique, but what I want to tell you is use of data, even using very simple methods, can give us deeper insights. Quite often, the data is available in paper form or in PDF reports. You don't always have data in Excel sheets in India. So this is the work that Sharan, who's here in the workshop here, was doing during COVID. So what happened was during COVID, quite often we were, asked to predict like astrologer that, okay, should we do lockdown? Should we not do lockdown? So it was really, very hard for epidemiologists. So we wanted to be a little bit more evidence driven. So then Sharan and our team, we decided that, okay, let's look at our data in a little bit more granular way and see whether we are able to give a little bit better guidance rather than, every time sitting in a meeting and saying, okay, maybe you can do it, maybe you should not do it. And it was really hard. And most of the lockdown decisions, as you know, were driven by many other socio-political factors and not necessarily by data. So what we did, we started every day extracting data from the government reports, which they used to put out on a daily basis. So we did the reverse engineering. We had to go from PDF to Excel. And then we ran a lot of analysis, and we tried to narrow down the variables which we felt were important to know whether the disease spread is likely to increase in a particular district compared to the other. So that we could say that, so there were limited resources, right? So if you know that you are likely to have a spread in the next 2 weeks in district A, compared to B, then you could direct your resources there. So that was our idea. And using very, very simple algorithm, we worked with some of our colleagues who were doing this kind of work internationally as well. And we took their inputs. We came out with very simple variables and an algorithm which could fairly well predict where the next hotspot will be. So using this, we used to generate these maps, and every week we will share these maps with the policymakers. So as you can see, we generated 4 levels. Green means don't need to worry about it. Yellow means there's a moderate outbreak or possible start of a growing outbreak. 3, need to worry about it. Okay, so that's when we tell them, like, you really need to put your resources, increase your surveillance. And red is when you do the lockdown. So using this sort of a graded approach, we were able to give little bit better guidance than what we could give just based on those paper-based reports, which used to be there on the website. So another example, and this is from Dr. Rizwan's work, and he will answer your questions in the end if you have, because I don't understand. So the problem I can explain you. So there are certain pockets in India where we have what we call as, acute encephalitis syndrome, that there are children who die due to brain fever. And it's a very serious problem. It's been reported in many pockets in Uttar Pradesh, Bihar, and so on. And the challenge is that this can actually happen due to several etiologies. It's not just one bug which is causing it, which are very different. And the treatment of these etiologies is also very different. So you have something called scrub typhus fever, which is very easy to treat. And then you have Japanese encephalitis, for which you actually need to refer the patient to a higher facility. So, so what Dr. Rizwan worked on was that there was already a lot of data available that can we at least stratify who should be referred and who should be treated in the primary healthcare. So he used several parameters, and he will tell you more about it if you want to know, from the clinical examination, from the laboratory investigations, and from the cerebrospinal fluid, which is taken from the back when to assess whether what kind of infection is there in the brain. And he came up with a kind of model which helped predict what is the likelihood. You cannot say for sure, but is the likelihood of scrub typhus more, or the likelihood of Japanese encephalitis more? So, and then he tried to use this tool in the practice to see whether it really works. So I think I'm keeping up the time. So just I've come to the end of it. So I think a lot of these data which is generated is very useful data, provided you ask the right research question. So I want to go back to that. Please make sure you ask the right research question. And these kind of data can help alert the health system, as I showed you the example from COVID, but you can do it for dengue and many other outbreaks. Design prevention strategies. Vector control can be stepped up in outbreaks like dengue. And in context of COVID, it was very important to actually get the logistics in place. So if you know that the COVID is going to be more 2 weeks down the line in a particular district, then you actually move your beds there, because the beds were limited at that time. Then the nurses were limited, and you could say that you could deploy your nurses in that district. So your logistics and overall avoiding the panic, it was very helpful. And so data can really drive much more evidence-based decision making than the lack of data. So even simple analysis helps, not just very advanced, complicated analysis. So just to summarize, identify the relevant research question in consultation with public health or clinical experts while designing your studies. Don't just ask for data. So next time, if one of you come and talk to me about research question, and don't say what data you have, okay? Data, you can find data. Even if we don't have data, we can look for data sources. Apply basic research methods first, and then whatever techniques you are using, it's like the icing on the cake, but make sure the cake is baked properly, right? So make sure that the core methodologies are correct. And then identify if already available databases are there. Collect data if data is not available. Otherwise, don't waste your time collecting data. Analyze existing databases. This is important, and it was emphasized a lot yesterday also. Ensure adherence to all regulatory and ethical procedures while working with public health data, because it is mostly quite sensitive. You saw that very nice 2x2 table, which Dr. Anurag showed yesterday. And we were discussing yesterday, a lot of public health data is in the high risk zone. So you need to be very careful. Not all, but quite a lot of, especially in outbreak situations and so on. And simplify, like you can do any model, it's fine. I mean, and publish it in your peer-reviewed journal and get credit as an expert. But if you want us to use it, or if you want Uma to use it, then you need to tell us in a way that we understand. Simplify and communicate your findings to those who can actually use your work. Thank you very much.
Hi, nice talk. So you talked about heart diseases and pollution in cities, and also collecting data based on geography, either cities or urban. So while collecting data, do you consider the dietary patterns of different groups?
So what I was trying to say was that if you want to study the linkage between air pollution and heart attack, you need to collect all the other risk factors for why someone gets a heart attack, which includes not just diet, which includes literally everything, whether they have diabetes, whether they have hypertension, what is their age, what is their family history. So all of that, that's what I said. So it's not that you cannot study association between one exposure and outcome unless you have collected data on all the other exposures. And that need to be taken into account in your analysis. But whatever literature has emerged from the West is from very well-designed studies, which have shown air pollution as an independent risk factor, irrespective of all the rest.
The girl in the back, yes.
Thank you for this talk, ma'am. Ma'am, I just wanted to know that when you set those thresholds for alerting the authorities, then what is the logic behind keeping those thresholds? Because those are not available like in literature. So what are the parameters that you use to set those thresholds?
Yeah, so we use pretty standard parameters. We looked at the change of incidence over time. Incidence is number of cases for 100,000 population, which is very acceptable epidemiological parameter. We looked at the test positivity and we looked at the availability of beds. And in context of COVID, globally, those were accepted parameters to see whether an outbreak is spreading in a particular community. We used the standard literature which was available. WHO had brought out guidelines and there were many such guidelines already available at that point of time. Of course, what applies in an outbreak situation may not apply otherwise. That's a different issue altogether, but I'm talking in context of when the outbreak was active. So those were relevant in that context.
Does it change like state-wise or population-wise? Like what are the standard parameters to keep?
The thresholds vary by disease and by the outbreak situation. It's not standard, but then you need to study that particular disease and that scenario and come up with the thresholds. So the best way to drive threshold is to actually do surveillance. So if you look at what they do in most of the Western world, they've been collecting data for like decades. So they know the pattern, what is a normal pattern in a population. So let's say if you don't have an outbreak, how many people will get influenza or how many people will get dengue? And once you have this pattern for 1 year, 2 years for a particular population, then with that threshold, you can see, do we have access? The problem for us is that if you don't have that baseline, then you don't know whether you have excess cases. But since this was a pandemic situation and in COVID, everything was excess basically, so that problem did not arise. But normally for driving threshold, you need to do surveillance over a long period of time. And then you use certain mathematical methods to actually define what is normal and what is above normal. Yes.
Thank you, Dr. Prabhdeep. So thank you also for showing the papers that have been using models. So this is a very famous example before 10 days before WHO alerted about COVID, a Canada-based company, Kamran Khan is the founder. He alerted based on heterogeneous data sets that a pandemic is emerging. They did that for Ebola also previously, Lancet papers, etc. And the paper that you showed from China, deep learning model for influenza prediction, multi-source heterogeneous data in a mega city. The most important predictor in this model was Baidu searches for ILI, interstitial lung injuries. So do you see the public health professionals' roles being completely, I think, being rethought about working with heterogeneous data as well, and not only the traditional sources of data that we collect on the ground? And do you think that NIE as an institution is looking at that as maybe a data integrator organization, which not only collects these field epidemiological data, but also these coincidental heterogeneous data sources to help policy? So I think
Yeah,
something on the lines that we've been discussing about previously as well,
Yes,
but
yes. So I agree with you. The thing is, see, traditionally, most of us we have epidemiology training. So we are not data scientists. So we don't have the expertise to work in those kind of data sets. But the fact that two of my colleagues are here in the workshop tells you that we know this is important and this is the way forward. And I agree with you, going forward, we will be looking at all these disease occurrence, risk predictions very differently. And unless we work together with other disciplines, we are not going to make progress. And coming to NI, I think we have data sets, as I mentioned, from diverse areas already available. And some of the other data sets which I was mentioning, they're actually in the public domain. Like if you want to look at climate and GIS and so on, what in my opinion is needed is really the expertise to bring them all together. And if we do that, we'll be able to make newer interpretations, which we haven't been able to make so far.
I agree. I think it's very uniquely positioned because none other organization would know the organization would have the kind of epidemiological data.
Exactly.
And it's probably easier, I'm assuming, with our work also before, to work with these heterogeneous coincidental type of data, which can be gleaned from the internet.
Absolutely.
And creating a resource like that and showing value could be
Yeah,
one.
sure. Definitely. We are happy to collaborate.
Thank you. Let's thank Dr. Kaur again.